First, I'd like to welcome everybody here. Thank you all so much for coming out and supporting our students. Second, I would like to thank all of the students. This is the last day of sort of the culmination of 4 weeks of really hard work, and I mean it's just been a pleasure working with every single one of you guys. It's been great. I think this is the best year ever, and I'm really impressed with all the groups. I think you guys will all be impressed as you see this work. I think I should also say that all of these results have already been sort of given and communicated to REAP faculty, the people in charge of the different projects. Some of the suggestions that you're about to hear are related to the projects are already being, plans for implementing them have already been, are being discussed, and they're figuring out how to logistically do them. So it's exciting stuff. And so I hope you enjoy, ask hard questions, challenge them. I'm sure they can all stand up to it, and enjoy. Go ahead.
Thank you everybody for being here. We as a group present to you cataract treatment in rural China. Before we begin, I'd like to extend a thank you to all the people who have supported us, the Shanxi Normal University, mainly some faculty members in there. Without further ado, we present to you cataract treatment in rural China, barriers, implications, and solutions. Thank you. Led by our great leader, Matt Boswell, we have 7 people, although only 3 of us are here today. For our presentation, we have divided this presentation into 5 main parts. 1, the problem, where the problem lies. More importantly, what is cataracts, how to treat it, and all those things. Objective, what we set out to accomplish during our mission in China. Approach, how we took to that objective. Results of the approach, and finally the solutions to the problem. So for the problem itself, what are cataracts? Cataracts are an eye disease caused by protein accumulating behind the lens and eventually blurring your vision to the outside world. It is the most common cause of vision loss over age 40 associated with age, responsible for almost half the world's blindness. How do you treat cataracts? Long-term solution, there's only one: surgery. Surgery is rather low risk, and it's also very short. As you can see, it's only 10 to 15 minutes. Some expert surgeons can cut that down to 8, but usually it's around 10 minutes. It is a low risk procedure, and it's very transformative. You can go from basically almost blind, not even able to see your reaching hand, to be able to see almost 20/20. So the benefits of cataract surgery, there's a lot of improved quality of life. There's a lot of socioeconomic outcomes. Here are just some from citations. It's also highly cost effective, meaning that the money that you invest into the surgery, you'll eventually get back at a larger outcome. Here's some more benefits of cataract surgery. Restoration of vision can improve household economic status. Here are just some statistics that we found about cataract surgery and the participants that come out of cataract surgery. Okay, on to the prevalence rate of cataracts in China. So surveys in China have shown prevalence rates ranging from 18 to 57%, although it's in various areas of the country, meaning that rural areas of China will usually have a higher percentage of cataracts, at least untreated. Cataract is noted as the leading cause of visual impairment in adults in China nationally. What about the developing countries? India prevalence rate is comparable to China. It's almost the same, 53 to 58% in rural India. However, China's surgical uptake rates are much lower than India's. The surgery uptake rate comparison, China's only 0.8 to 12 people. That means 1 in 120 people will take the surgery, while in India, 7 in 10 people will take the surgery, which is a major comparison. So why is cataract surgery uptake rate so low in China? So there's a few large-scale studies showing why China's surgery uptake rate is so low. Although there's very, very little dependable resources, and that is why we needed to go out to the field and interview for ourselves. In other words, we don't know. That's why we went. So, objectives. What are the 3 main objectives we set out to accomplish? Sorry about the 111. That's the formatting. 1, determine the most salient barriers and what is preventing them from getting care. 2, to better understand the implications for not getting this cataract treatment and eventually not getting that socioeconomic outcome. And finally, to design a solution that overcomes all of that. For the approach, first we conceived of several hypotheses. We drew up a causal chain analysis, and we came back and looked at what is causing it to stop patients from going to get cataract surgery. And by going to the field and interviewing stakeholders, we tested whether these hypotheses were accurate. So on the supply side, as we know, supply is basically the hospital, the doctors. So 1, we had the lack of will on the part of county hospital doctors, administrators to treat the condition. So the most local hospitals to those patients. 2, lack of qualified surgical and support staff at the county level. We classified this as software. Lack of appropriate surgical equipment and space at the county level. So that means this is a hardware problem. And finally, lack of screening capacity to reach rural areas. And this also means the communication between the hospitals and the patients, and also the spread of awareness of just cataract surgeries. So the demand side for patients, lack of awareness of the condition, lack of awareness that there is a problem, also lack of awareness of the socioeconomic outcomes. 2, individuals, families do not place concern on care for this particular condition. In China, we have this thing called competition for the wallet. We might want to spend it on something else rather than this illness. We could spend it on education, living expenses, disastrous illness. We're just saving up for that, and we're not using the cost that we should be using for cataract surgery. 3, lack of trust in the local doctor, the closest doctor again. And finally, seeking care from qualified doctors is too costly. They just don't have the money to afford it, whether it's direct or opportunity cost. So to test these, we went out and interviewed stakeholders. Supply side, so the doctors and the hospitals, we interviewed 11 people. We interviewed 2 main categories, public and private. This is very important because it's going to show up later by my colleagues, and they're going to talk about it and what's the difference between the 2. But basically, these are all the doctors that we interviewed. Mainly, we want to point out a few. It is that some of these doctors didn't have the opportunity to perform cataract surgery, and these are all very important people, and we'll see the results of these interviews later. So on the demand side, we interviewed 36 patients, interviewees. So ordinary rural people in townships, villages, and county seat, not necessarily at risk, 15. Elderly people that have undergone cataract surgery in the past, 4. And elderly people that have cataracts because we screened them, have not undergone surgery, 21. So this is the main category that we wanted to focus on. How do we know? We took doctors to the field, and we also trained our fabulous crew to go screen them. Matt Boswell, our great leader, screening patients. We took some training. Our crew also, Ami Hayashi, student at Stanford, screening patients. Austin Wynn, another person in our group, screening patients. Another 2 members of our crew doing visual acuity tests for the patients. Finally, our doctors that we brought, their expertise in this visual department, we took to the field, and they screened us for it. So for the statistics of the field screening, we interviewed a total of almost 200 people. We screened a total of 200 people, sorry. 45 people have cataracts. This is a major issue. Now, you might ask, oh, why is it not like the 57% that we were just talking about? It's because we didn't control the population of those people who came, and we didn't have like kind of a control over those people that came. So we had like 30 years old, we had 65 years old, we had all kinds of different people, and it wasn't the intended population that we wanted to screen. Now, of those 200 people, separately, 47 people have other eye diseases. And one that is very particular is pterygium, which is basically meat from outside the eyeball growing into the eyeball. It's very disgusting. But a total of 75 eyeballs with cataracts require surgery, and a total of 76 eyeballs with pterygium require surgery. So, now what we all anticipated, the conclusions from field screening, 50% of the people that required some sort of eye surgery, and only 1% of the people needing surgery had undergone surgery in the past. 83% of the people who require eye surgery needed both eyes fixed. What's the key takeaway? They're not getting it. Now I'll pass it on to my colleagues to tell you why.
Okay, so what did our interviews reveal about our hypothesis on why uptake for surgery is so low? So our first hypothesis was that there was no desire on the part of the county hospital doctors to treat this condition. And so through our research, we found that all doctors that we interviewed at either the county or prefectural level could not perform surgery, were eager to learn. So none of them seemed against the idea of like being trained to do surgery. They all seemed pretty eager to learn it. And among these, one county doctor actually asked to get training, but the hospital never followed through with this. And so we connected this experience with the idea that like many surgeons or many hospitals expressed concern that their trainees would leave once they were capable of surgery because wages are better in urban hospitals, so they'd leave the rural areas and go to better jobs. And one director, Renju Ren, said this, and this was a common idea that we faced in many hospitals. And so our key takeaways for this idea was doctors are willing to learn the skills, but many local doctors may not stay if they learn how to perform surgery. And so our second hypothesis was there's a lack of qualified surgical and support staff at the local level, which we labeled as the software. And so we assume that all doctors at the county level are willing to become surgeons. And one director reported only about 15 to 20% of need is met per year at the county level, which Shaanxi has enough cataract surgeons per population according to China's standards. So this shows that none of the doctors are spread out. They're all like contained in the urban areas since that's where the good jobs are. And this is possible, so yeah, because they're all in the wrong places. And prefecture hospitals reported no plans to transfer capacity to county hospitals, and they had no effective training programs in place. And this is because they don't want to share their wealth, since the doctors that are in the urban areas are doing really well, so they don't want to share their jobs with other doctors and their money. And a hospital director said that a cataract surgeon can make almost 500,000 RMB per year at an urban hospital serving fee-paying patients. So this shows they can make a lot of money being in urban areas. But fixed costs for surgery goes up as you go up the ladder. So as you move closer to urban areas, become more expensive. So like the price of a private hospital in Shanghai costs almost like 1,000 RMB or 10,000 RMB. And then a price of surgery at a county hospital is 1,800 RMB. So it's 1/10 of the price at Shanghai. And so our key takeaways for this were there are few surgeons below the prefecture level, and the people seeking care tend to be those that can afford to pay higher fees out of pocket, and urban doctors don't want to share this pie. And so our third hypothesis was there would be a lack of appropriate surgical equipment and space, which we labeled as hardware. And we were actually really surprised. All the hospitals seemed to be doing really well. They all had high-tech equipment. Like they had like escalators. Like in the last photo, that table cost 500,000 RMB. And this is because they all said that the government, which is called the Shengmian, was pouring money into the hardware. So they were all paying for new fancy buildings. And every public hospital also said that they could get equipment if they wanted to. So obviously this showed us that hardware was not a problem. The problem was that there were too little surgeons. And our fourth hypothesis was there was an insufficient outreach to rural areas. And no hospital reported having a systematic outreach program for rural areas. The staff reported that rules limit how patients can be processed in a county hospital. These rules assume patients will be able to travel to the hospital by themselves without help from the hospital. And this, we also found the iron rice bowl effect, which was all government workers are paid no matter how much they work. So since people are lazy, they don't really want to, if they get paid the same amount, they don't really want to, they don't have an incentive to help more people since they get paid the same amount if they didn't help as many people as they could have. So so one person said there's not much change in my salary month to month. And county hospitals and township health centers were really scared of risk, because since when you were there, the roads were really windy and there are a lot of mountains. So many of them were scared of car crashes or or cars falling off the road. And so none of them wanted to be responsible because whatever happened to the patients, they're reliable for them. And also, rural patients can't pay much out of pocket. So both of these ideas makes them not have much incentive to go out and treat patients for cataracts. And so our key takeaways for this was there's little outreach activities in public healthcare system, and they also don't want to take risks. And so the demand side hypothesis. So first one was there's a lack of awareness of the condition and lack of awareness that there's a problem. So this was a common problem that we faced when we were interviewing people, because many of them did not know what cataracts were and they only came to our screening because they just happened to be at the place at the right time. And so out of 36 demand side interviewees, 5 had never heard of cataracts before at all, and 16 had heard the word before but didn't know what it was. They just thought it was something they just knew that had to do with your eye. And only 1 had an understanding of what cataracts were, and this is only because their mom underwent cataract surgery before, otherwise they probably wouldn't have known what it was at all. And many people confuse cataracts with other eye problems such as pterygium, corneal opacities, glaucoma, conjunctivitis, and and because there's what I said before, they don't really they don't really do much outreach, so who can blame them for not knowing what any of this is? And nearly all elderly interviews reported that they only would go to the hospital if they they had something catastrophic, like they broke a bone or needed really extreme surgery. But none of them actually think of cataracts as a really catastrophic or big need that they need help with. And so many patients reported that health problems are just part of getting old, so they just wait them out. And some people were scared to tell the younger generations that they had a problem, since the younger generations, they don't want to burden them with their problem and have to make them stay and take care of the kids. And then 2 interviews reported being too afraid to go to the hospital. And so 2 cases we encountered were, one case, a man had bug larvae growing in his eye, and he only sought treatment because we were there at that time. Otherwise, he probably would have waited until he was fully blind to go to get surgery. So we had to scoop it out of his eye. And another case, a man got a piece of metal lodged in his eye while welding without a mask. And he did nothing for this for about 2 months, which was a really long time of just the metal being in his eye until we were at the township for screening. So both of these people probably would have never gone to the hospital for these things, and they're both really extreme cases, but they didn't really think of it as anything that they needed to go to the hospital for, and so they probably would have waited it out until it affected their daily lives. And our key takeaways for this was there's low awareness and understanding of cataracts, and patients take a passive approach to health management. And so our second hypothesis were families might not place importance on cataracts, and 2 people stated that they needed to get approval from their son or daughter before agreeing to undergo any treatment, and 1 woman did not want to take the note for her screening because she didn't think her sons would believe her. And then another woman said that she thinks she's going to die anyway, so she might as well like not get treatment. And so the director from the county private hospital we interviewed, Renju Ren, said that the 3 main reasons for people not going to the support of their parents getting surgery was because they don't understand the condition, they don't care what happens to their parents, or they don't know that their parents suffer from the condition because they don't want to have a burden for the family. And so this patient that we interviewed was named Yang, and his son was sick for 8 years, his daughter-in-law had been sick for 4 years, and his wife also suffered a stroke, so all of these diseases seemed really big in his family compared to his cataracts. So especially since they paid almost $500,000 RMB for these treatments, they didn't really want to spend money on his eye problem because they didn't really see cataracts as a pressing issue. And so he's also never done a checkup on his eye, and he only did this because it was free and it was nearby, and he really wants to get surgery and hopes that it's free. So our key takeaways for this was the healthcare of the elderly is not a household priority, and this may be among the most crucial barriers to care. And our third hypothesis was there's a lack of trust in the doctors. And a repeated response that we faced was if a doctor came out to a town clinic to perform surgery, that he would do it, but the town clinic just offers surgery, he would not do it there because he thinks that the quality of the surgery would be bad in the township clinics. And so we took this as there was a lack of trust in local expertise, and this is also a significant barrier for care. And our fourth demand side hypothesis was seeking care is too costly. And so many people said that they were willing to undergo surgery if it was free. So cost was stated as the biggest burden for 8 people. And most of the people we met at the private prefectural eye hospital had known about their cataracts for a long time, but they didn't go to get surgery because it was too expensive. And at Renju Ren's hospital, he paid for the portion of the surgery not covered by rural insurance, and he found that during the time when he charged 100 RMB per surgery, fewer people sought treatment. And so also when we interviewed families, almost everyone knew the exact price of their son's wedding, but none of them seemed to know the price of the reimbursement rates or anything. And so this showed that the kids prioritize their kids getting married over their parents' health. And so a son's marriage costs about 100,000 to 500,000 RMB, and education costs at least 280,000 RMB. So this shows that they're both really expensive, and when it comes to their parents' health, it's they don't really want to spend more money than they have to. And so our key takeaways from this was cost may be the most salient barrier to care, especially given the fact that qualified doctors are almost always distant and they're all in the wrong places. So the people that actually need surgery, they don't really have the opportunity to go to the hospital. So now what? How can we make sense of all of this? So I know we gave you guys a lot of information, so we categorize this into 4 different categories to show the relationship between each key takeaway. And so if we add all our key takeaways together, there are a few surgeons below the prefectural level. And this we put this into the category of low local capacity. And then we also found that there was little systematic outreach activities in the public healthcare system, and the public healthcare system has little incentive to innovate and take risks. And both of these ideas go in the category of low outreach to rural patients. And then we also found low demand among rural patients. And so the key takeaways that fit into this category are their low awareness and understanding of the condition. There's a passive approach to health management. Healthcare of elderly is not a household priority. There's a low level of trust in local providers. Cost may be the most salient barrier to care, especially given the fact that qualified doctors are almost always distant. And so this demand problem ultimately leads to a low supply problem, as since there's low demand, doctors don't have the incentive to treat in rural areas. And so the key takeaways that we put in this category were local doctors may not stay if they learn how to perform surgery since they want to make more money. And the people seeking care tend to be those that can afford to pay higher fees out of pocket. And urban doctors don't want to share this pie. So taking all of these categories together, we see the vicious cycle And so each category leads to the next. So low local capacity then leads to low outreach to rural patients, which then leads to low demand among rural patients, and then leads to no incentive to treat in rural areas. And then that leads to, again, to local capacity. And this cycle repeats itself unless we do something to solve a problem. So what are we going to do about this?
So we're going to look at a few short-term or low-cost solutions first. So in order to deal with few surgeons below the prefecture level, we're going to train new doctors at the Zhongshan Ophthalmic Center, which is a long-standing partner of REAP, in order to train new doctors that can complete cataract surgery at the county level. So you might be wondering, how do you train a cataract surgeon? Well, it can be broken down into a few simple steps. The first step is a wet lab training in which these trainees will learn the theory behind cataract surgery. Step 2 is a hands-on training where these trainees will learn to perform the surgery on animal eyeballs. In step 3, the trainees will return to the hospitals and learn to perform surgery on patients under the supervision of trainers sent from the Zhongshan Ophthalmic Center. And in step 4, after 30 to 50 surgeries under supervision, they'll be able to carry out the surgeries on their own. In order to deal with local doctors not staying once they learn how to perform the surgery, we'll be identifying candidates who not only have necessary certification and training status, but that have a low flight risk by looking for indicators such as school-aged children and spouses that have a good local job. And to deal with the little outreach activities that the public healthcare system puts in place, we'll be conducting screenings at the township and village levels. And our hypothesis is that the most efficient way to reach large groups of people is by screening at the township level. However, for the rest of the summer, we'll be screening at both locations to further evaluate the number of screenings done and the number of completed referrals. And with cost being one of the most salient barriers to care, we'll be providing free or reduced cost surgeries for most patients using government reimbursements to help fund the rest of them. And a portion of patients with high-level socioeconomic status will also help to pay for the surgeries of the people that can't pay for it. And we'll also make screening available at a local level, meaning that these patients aren't going to have to travel very far in order to discover whether or not they have cataracts, because they won't have to pay for the travel costs as well as any other living expenses that they might have to deal with if they went further away. And patients will also be offered a surgery slot immediately, meaning there's no wait list, because a lot of the times if patients go to the city hospitals, they'll have to wait for up to a week before actually getting treated. And we'll also be offering free transportation to patients that we identify during local screenings. And the patients will be accompanied by hospital staff or community volunteers so that we can ensure their safety during the long journey. So in order to deal with the passive approach to health management that most patients take, we'll be doing direct-to-patient screening in villages and townships, and we'll also be picking them up so they don't really have a reason to not be seeking treatment. And for our longer-term solutions, we have a social enterprise hospital planned to deal with treatment for all of these patients. Again, we'll be training all of our doctors at the Zhongshan Ophthalmic Center by facilitating hands-on training for REAP's Vision Center refractionists. And we'll also be addressing issues such as urban doctors having no incentive to share their profits. We'll have the ability to create our own contracts with doctors and make attractive offers that they can't refuse. And we'll also be able to shift incentive model to promote free surgeries. So essentially, by placing this social enterprise in the prefecture, the full paying patients that are from the prefecture will be able to help subsidize the surgeries of the patients that can't pay for it. And when the public healthcare system has no incentive to take risks or innovate, our social enterprise will be private, so it doesn't have to follow the limitations of a public hospital. And since innovation is necessary to contribute to effective patient-centered model, we'll also be able to forego the risk aversion that the public hospitals take. And in order to deal with the low level of trust that the local patients have with the local doctors, the Zhongshan Ophthalmic Center is essentially like the Stanford Hospital of Eye Centers in China. So by having our doctors train there, we'll be able to kind of advertise that, and there will be a higher level of trust among patients. And to deal with the low awareness and understanding of the condition, since we'll be screening patients in their hometowns, we'll also have people around to explain what the condition entails to these patients that have cataracts. And with healthcare of the elderly not being a household priority, we'll be able to design a protocol to ensure family members with power that the surgery is a worthwhile treatment for their parents, and we'll be able to discuss that with them when we pick up the patients. And in order to subsidize costs, the people seeking care who can afford to pay higher fees out of pocket will help subsidize the costs of these patients that can't pay for their own surgeries. And since when we talked to Renju Ren, we learned that a lot of the times patients will not they won't get the surgeries if they have to pay for it. By providing these low cost and free surgeries, we will hopefully be able to increase the uptake rate. And we've also talked to a lot of experts who said that outfitting a building to provide these surgeries will cost about $800,000 US, which sounds like a lot, but in terms of creating a hospital in the US, that would never be possible. So it's actually a great opportunity to try and treat these patients. Thank you for watching.
So just as a postscript before you ask any questions, the short-term solutions are underway right now. We actually are just signing a deal with Zhongshan Ophthalmic Center. We have 4 candidate surgeons who are going to begin training in a couple weeks, and the patients that we identified in this field screening will get surgery later this month from ZOC, from Zhongshan Ophthalmic Center, and our trainees. So on the basis of what we found, this is actually we're moving and we're implementing. So nice job, guys, for helping us understand the problem so clearly.
Getting permission from the person in the family that I guess pays for it, usually like the son, I guess, or the grandparents or the children. Could you guys just talk a little bit more about why that's important?
So a lot of the hospitals in China won't do any sort of operation on elderly patients unless they get the sign-off from their son or daughter. And that's pretty much just because they've encountered a lot of cases where the elderly patient did sign off on it on their own without necessarily getting permission from their son or daughter. And if something went wrong, their son or daughter would go to the hospital and blame them for it. So in a way, it's just kind of, again, following along with how they're really averse to risk, so they're just trying to avoid any risk in that.